I want to move now to a subject which really seems to be splitting the NHS in half, and that is the role of the physician associate. So if you're not familiar with this, the physician associate was originally called the physician assistant. It's a really an idea, I guess, borrowed from the United States, where I saw it in action a great deal. The idea being that you bring people in who can take the burden of work off doctors. So, for example, they can fill in blood forms, or they can run and get X-ray results, or whatever it is. It's a good idea in principle. The problem is that the British Medical Association and many doctors are deeply worried that their role has been expanded exponentially, and they're now doing things that they shouldn't be doing. Now, the government will argue, well, we're actually increasing the numbers of people who are helping doctors, but at what price? Joining me now is Dr. Laurence Buckman, GP and medical broadcaster. Good morning to you.
Good morning.
Really good to see you, Laurence. Where do you stand on this? Because the idea of having a helper, a friend as a physician who can do things which will liberate your time and your capacity to see more patients and to use your clinical knowledge seems like a good idea.
Yes, I think the original idea of physician assistants, they changed the title, as you said. The original idea was not a bad one. Doctors do all sorts of things that anybody else could do. You often hear patients say, well, I could have done that. So actually, it would be better if the doctor can be supported by people who are as effective, do the job cheaper as far as the NHS is concerned, and increase the ability of GPs to see more patients, which is what we all want.
Mm.
The problem comes when you make them physician associates, and then you confuse their role with doctors, or indeed with nurses.
Right. So why did they change? Why did they change the name then? Because clearly, actually, nomenclature, and that's another good word, nomenclature is really important here.
It's essential that people don't confuse these people who are very able and welcome helpers, confuse them with doctors. They haven't got a medical degree. They may well have a lot of experience, but I'm afraid it's not the same. And when they start prescribing outside their range of competence,
yes,
when they start not clearing up the fact that they're not a doctor when they meet patients, when they start making clinical decisions, ordering scans, referring patients, all sorts of other things, without a doctor supervising that directly, then problems arise because the patient is confused, the families are confused, and the NHS doesn't realise who's doing what. And actually, at a time of doctor shortage, the last thing we need is confusing these new people with doctors.
Well, I mean, so I've read this from various perspectives. There are currently 3,500 of them. The government wants to treble that number by 2037. I might argue that this is trying to get medical staff on the cheap.
Yes, that's exactly what it is. And I think that it's a mistake to think that you can put people who are not doctors into doctor roles and there won't be accidents. And there have already been accidents, unfortunately. And if they would have stuck to their role, then these accidents, a doctor might have made the accidents too, and there are ways of dealing with doctors who have accidents. But the fact is, most doctors are much more accident aware because of their training and experience. They know how to, if possible, avoid accidents.
So just clear up for people at home what the training is for a physician associate, because they don't have a medical degree.
They go to university and they do a degree and they have some vocational courses and they spend some time being clinically trained as well. And they're basically there as a doctor's helper. And if so, they're not a second-class citizen, as some of them have described themselves. They are first-class healthcare assistants, but what they aren't is doctors. And when you start confusing that role, patients and their families will not know who's doing what.
OK, let me bring in Roy Lilley now, a former NHS Trust Chairman. Roy, really good to talk to you as well. Your thoughts, please. I mean, you ran an NHS Trust. We know there's a huge crisis in terms of management and having enough doctors on the wards. Do you think physician associates, as they're now called, are a good idea?
Well, you know, I agree with Laurence Buckman, and you started this segment by talking about anniversary days. Laurence Buckman was the first doctor I ever interviewed.
Is that right? Well, there you go.
Yeah. So good morning, Lawrence. Lovely to see you. He's the world's best GP.
He is, and I can attest to that.
Yeah, it's lovely to see him looking so fit and well. I want to know what he's on.
Well, actually, I have to just jump in and say, Lawrence, I think it was one of your early books, was one of the first medical books I read. So there you go.
Yeah, I think whatever he's prescribing himself, we want some.
We do indeed. Right, anyway, back to physician associates.
Lawrence is right. They're a good idea if they can help out, but it's got into a horrible mess, and it's the usual story of the NHS. It's how it implements things, and that's the problem.
Well, you say that, but the physician associates will say back to you, well, now there's a toxic row brewing. We went to do it. I was reading about this lady Julia. She says, I love the contact I have with patients. I trained to be a physician associate, and now I feel really undermined.
Yes, there's a brow brewing, and that's on another broadcaster's website, and I've read that myself. And it's a tragedy, and it's not a single case. I mean, I think there are problems brewing everywhere. It's been poorly implemented. When they came in 2015, everybody thought it was a bit of a good idea. They're mentioned in the NHS long-term plan as part of the workforce planning, and as you say, there's going to be a lot more of them, over 10,000 by 2035. And if you add in associates for anaesthetists, it's 37, and it's a lot more. So I think people have kind of woken up to the fact that suddenly these people have arrived. It's not been implemented very well. Yeah. Have job plans which vary from place to place, and through custom and practice, some of them are taking on more than they perhaps should. There are now allegations about people being less than frank about what they are. Are they doctors or are they physicians associates? And so the whole thing's a mess. Now, Wes Streeting has now decided that he's going to have a committee look into it and report. The problem they've got with that as a technical issue is that they're not regulated at the moment. They will be regulated by the General Medical Council, which is the same group that regulate doctors. There's a lot of arguments against that. They should be regulated by their own body and not by the doctors' regulatory body, to avoid any confusion. And really, until Wes Streeting's committee is reported, and I have no idea when that will be, they really shouldn't be regulated in a formal way, because his committee might well say, well, actually, thanks very much, but we don't want them. So Streeting has added to the confusion, and the public, as Lawrence has just said, really don't know where they are. It's an implemented mess.
So Lawrence, let me bring you back in here. So as far as I can see, there's two things here. One is that the United Medical Associate Professionals, which is the body that looks after these associates, the physician associates, says this is toxic, it's bullying, so our members are feeling threatened by the actions of the doctors. The doctors are saying, hang on a minute, they're actually far more hindrance than they are a help to us, because I don't really know what they're doing. And there's another thing in terms of clinical training. They're saying because there are so many physician associates on the ward, then the doctors in training, or the junior doctors, can't get the experience like I did, like you did. As we say, see one, do one, teach one. If you can't see it, you don't get the experience.
That's right. They obviously are taking over certain roles within the ward in hospitals, and on occasion also in general practice. Patients don't know that they're seeing someone who's not a doctor. And there's nothing wrong with that, as long as the patient understands they're seeing someone who's not a doctor. I'm all for being helped. I'm happy to have more helpers. I don't see this as toxic. I think the confusion with the GMC looking after both physician assistants and real doctors, I think that's a mistake. And I agree with Roy that we really need to see that Streeting comes to the conclusion of exactly how and if physician assistants are going to, and associates are going to be part of the NHS going forward.
Roy, just in terms of the rotors here, and I wonder if this is not a fault of the physician associates. The NHS employers website is very clear about what they can and can't do. They say you can take medical history, you can carry out physical examinations and come up with a list of undifferentiated diagnoses. Now, suddenly there is this massive crossover, because if you are seeing the patient and taking the history and you come up with a differential diagnosis, that is the list of potential diagnoses, then I think because the minute you come down with a diagnosis, all the care treatment plans then follow on the basis of that which hasn't actually been done by a doctor. But what the doctors are saying is it's the trusts who are employing these people because it's much, much cheaper, and they're rotoring people on who are physician associates instead of doctors.
Yeah, and they are. There's no question about it. And you know, if I was to look into the mirror and think about my conscience, and if I was still running a hospital, you know, I think I probably might do the same thing. I might rotor some of these guys and gals because they are cheaper. A lot of them are really very good. They've been doing this job for a long time. They work under directions, and when you get used to working with people, there's a kind of porous boundary over what they do and what they're supposed to do. And as you just said, see one, do one, teach one. They acquire a knowledge through history and legacy. And so, yes, I mean, I think I probably would be rostering them because, you know, the NHS already this year is £4.8 billion in debt. Most of that is from workforce working overtime, trying to get the waiting list down. So I absolutely understand the pressures of why hospitals are doing it. And until they're told not to, they will do it.
And Lawrence, is my point valid? If you, and this is my biggest concern with, if you, the patient, contacts a physician associate first, and they take a history, and they come up with a list of differential diagnoses, and they say, right, we think it's this, then all your treatment plan and investigation plan is basically dependent on your list of differentials. Now, if your differentials are wrong, because this person is not medically trained, you will miss diagnoses.
That's exactly what will happen. And the only way around that is to organise physician associates in a way that says nothing goes past them without ending up with a doctor before any action is taken. And the difficulty, as Roy's been talking about, is if a trust is pushed to fill a rota, they'll put in somebody instead of a doctor, not as well as a doctor, instead of. They're not our servants, they're masters of their own domain, but what they can't be is completely independent physicians, because they're not. We can label them as what we like, but that doesn't make them able to make detailed diagnoses and treatment plans when there could be an error and no doctor check it.
So sorry, Roy.
Yeah, I was going to say, David, the issue here is that these are terrific people.
I was going to make that point.
Yeah, they're really great people. They want to do this job for reasons of their own history. Perhaps they've not been able to go to medical school, or perhaps they've matured later in life, or what have you. They're great people who want to do their bit for the NHS. And it's wrong that it's turning into a big punch-up, and it's wrong that, you know, we're sitting here criticising the system this morning. This has been badly implemented by people who are desperate to fill rotas, who are running out of money. It's been exploited. The BMA have rightly, you know, got out of their pram over it. And Streeting is just making the whole thing worse by not nipping it in the bud straight away. We all know. I mean, listen to Lawrence. He'll tell you what you do. Look, a list of undifferentiated diagnoses is a waste of time. You pitch up with lower back pain. OK, what could it be? You know, sciatica or a prostatitis,
or bony pain from metastatic prostate.
You know, I mean, it's a nonsense, really. But the thing is, it's very hard these days to get people to work in the NHS. Applications to become a doctor are down. Applications to become nurses are down. People want to work in the NHS. They want to do things for their fellow man. We should look after them, cultivate them, and give them a safe place to work.
Absolutely, well said. Sorry, I have to jump in. Thank you to both of you. Of course, yet again, we see systems failure. Dr. Laurence Buckman, GP and medical broadcaster. Roy Lilley, former NHS Trust Chairman.